Here. Good morning to everyone. Our speaker today is Dr. Angela Tyson. Our program is underwritten by an educational grant through OSU Medical Center, Graduate Medical Education. A disclosure statement has been signed and is on file in the Graduate Medical Education Office. Dr. Tyson graduated from the inaugural class of Edward Via College of Osteopathic Medicine, Carolinas campus in 2015. She came to Oklahoma State University for both her pediatric residency and decided to follow up with 1 year OMM fellowship. Afterwards, thinking that's not enough, added a 3-year fellowship in neonatology in the University of Rochester, where she's now an assistant professor of pediatrics in the neonatology division. Dr. Tyson researches neonatology outcomes on preterm infants utilizing OMM. I want to thank Dr. Tyson's also been a member of the American Academy of Osteopathy, Louisa Burns Osteopathic Research Committee and Grant Subcommittee for the last 4 to 5 years. Want to sincerely thank Dr. Tyson for filling in for the OMM department under such notice this Grand Rounds presentation. The Cloud CME activity code for today's Grand Rounds is 1577. Please welcome Dr. Angela Tyson.
Okay, good morning, everybody. Can everybody see my slides and hear me okay?
Yes, we can.
Okay, yep. Lovely. You're gonna have to forgive me. I am on service right now in Rochester for the NICU babies. And we just had 23-week triplets, of course, deliver like right at shift change. And I had somebody covering me for an hour. And of course, triplets fall from the sky. So I apologize for running just a few minutes behind. But I'm here today to walk you guys through how to design an osteopathic clinical trial. I have done quite a few research projects and just finished a major clinical trial on premature infants using OMM. And, you know, getting your data, getting results, publishing results is like a whole separate conversation that we are not going to have in this talk, but we are going to go through how you take an idea and make that into something. So we're going to learn how to form a hypothesis and specific aims, how to design a trial from your idea, and how you get funding to do this. So you have an idea. That's like super great. Some starting foundation things you need to say are, have you ever seen this done before? Is this a new idea? Is it relevant, significant, or important? And is there literature on it? Do you have anything to back up your idea? If this has been done before, you're likely not going to get it published unless you're coming up with some kind of data or outcome that has not been researched from your idea before. If it is not relevant to a field, if it doesn't have a significant outcome, if it is not something that is very important, no one is going to fund it. And if you don't have anything to back you up, you're going to have a real difficult time because you are starting from absolute scratch, which is commonly the situation that I'm in, at least from data in the United States. But if there's nothing to back up your data, you are really, really starting from the ground up, but it can be done. So a literature search, the first thing you're going to do after you get your idea is you're going to go out and you're going to look to see who's done what to answer those questions we just stated. It hasn't been done before. Is it relevant and significant? And do you know what's coming of this? Because if there's really nothing to support your idea, we got a whole different process of thinking. But usually when someone sparks an idea of something osteopathic, there's something out there, some reason that that interest is being sparked, that that idea is coming forward to support something that's probably been done very similar to that. So if you start pulling literature that is relevant to ideas that you have to know how to critique your literature. And do I have a lot of people? If you are a resident and you have to give a journal review article, how many of you guys have to do that? I don't know that I can see. I don't know why I just asked something I can see. I'm assuming a whole lot of you, right? Yeah. So these questions are something that I can email out when this presentation is finished, because these are questions that will guide you through and take you through like all of your training and all of your career, even as an attending, for how to sit down as a group and review a journal to know whether or not it has significance to either apply to your clinical practice or to add to starting to form a hypothesis and specific aims. So a study design, first off, if you got this idea to run a clinical trial, you're going to need to be looking for literature that has done something similar to a clinical trial. So when you're looking at a study design, you're looking for literature that they have used in that study that is thorough, that is current. It reviews things that are directly related to their research problem. You want to know whether they're using a theoretical or an actual conceptual model. Is this something new, or is this like a well-known thing? Did they do a retrospective study? Did they do a case control? Like, what did they use? And was that model appropriate for what they designed? So these questions are gold, because this makes you sound real smart when you go to your group and you're like, so I think this model XYZ, and these are going to give you these foundations. So we're going to keep on going with this. Maybe. Here we go. The next is sample selection. How did they select their subjects? What kind of inclusion and exclusion criteria did that journal specify? And how representative of their sample selection is that of the questions that they're asking and the data that they're publishing? And was there selection bias? So these are really important questions to answer, because if your samples are not adequately representative of the data that you're publishing in a conclusion, there's some issues there. Next is the method design. Is this study design actually appropriate? And how is the research conducted, like physically the study itself and data collected? What they do with the data and how it's stored and who is blinded, and HIPAA kind of things are really, really crucial. So the steps that are taken through the method and design is really important to have protocolized and extremely specified. And then, are the written methods sufficient enough to be replicated by another center? If your research can't be understood well enough, or somebody could take this and say, you know what, they did like 20 patients, and I'm going to take this and I'm going to do something bigger and see if I can come up with the same thing. If somebody can't do that with what you publish, there's a problem there. And then, did they have IRB approval obtained to do this? Analysis. You should really look at how someone defines their primary and their secondary outcomes, and were those appropriate to what the data is reflecting? How is that data analyzed? What specific statistical tests are appropriate and can help you know whether this data was interpreted adequately, and was the study powered? That is very important. So we'll go over that in a little bit later for how to design. What your power shows is really going to tell you a whole bunch in a clinical trial. And then your results. What are your findings of the study? Are they presented in a very clear and understandable way? And are those results adequately and accurately interpreting what is significant or maybe insignificant? The biggest thing I see, and I'm on a, like Dr. Ty said, on a grant subcommittee. I also review some pediatric publications for journals from the AOA. And the biggest thing that I'll deny an article for is someone taking a conclusion that was inadequately drawn from a result that they got that they thought was significant as a bias, when really that's not what your data is saying, and you can't draw a specific conclusion. That's going to get you in trouble. Okay. But these questions and these slides are things that I'd really love you guys to keep, because I tell our fellows here, I'm like, here are these 5 slides, literally copy and paste these onto a PowerPoint. And when you guys are going through, you pick your journal and you want to review for the group, like we literally can walk through this journal question by question by question, and it leads to a foundation that is very adequate and accurate for interpreting the data. Discussions. Does the results support the hypothesis? Did the author adequately discuss the results in relation to the clinical practice that topic is talking about? If you come up with something that's pretty neat, but it has absolutely no application to the population that's being studied, that is not very helpful. They should always talk about limitations to the study. It doesn't matter how perfectly you think your design is, there are always limitations to what you can do and limitations to what happened while you were conducting the study. How does this study contribute to a total body of knowledge in that field? And what additional questions does that study raise? If you ever go to a conference and you do a poster, every single time you do a discussion, it should have what you were limited on, and then what you learned from this to start doing other things, next steps. Those are crucial to have. So you review your literature. First off, are there any questions before I keep going on those? No, you all got it. Okay. So hypothesis and specific aims. I know you've heard this since like probably some kind of K through 12 school, right? Like, what is a hypothesis? It's your question. What are your aims? But when you actually go to write this for a study, this is probably the hardest and the most time-consuming part. So what makes a good hypothesis? You have to ask a question that is making some kind of prediction about some outcome and some kind of specific population. So you can't just say if and then, like if I studied bubbles, it will produce blank, you know. You have to come up with, I think this is going to improve something by 10% on this population at this place and time. You can't just make an assumption. So that is probably the most complete sentence I think I could come up with what a hypothesis is. You have to be able to test the prediction that you're making and actually observe it in the study that you're doing. And less is always more. Take out ambiguity, take out wordiness. The less words you have here, the more simple and understandable it is, the better it goes. This should be like a 2 to 3 line sentence max. It can take a while to get an idea to that point and that simplified. And then what are specific aims and what are the purposes of this? It took me to like grant writing courses and probably fellowship to really understand why I needed some kind of goal that I was studying besides what I was trying to state in my hypothesis. And this is to address the fact that, well, you're predicting A will cause B, but what happens if A doesn't cause B? What you gonna do then? Because now your study did not show what you thought. And whereas data is important to publish about things that were not what the hypothesis were, there's always an opportunity to look at some outcomes that could be very relevant and near to what your hypothesis and prediction is that you should also think about as a backup plan per se, or just as other observations that you are gonna most likely know you're also going to be able to draw from the study that you're doing. So these are called primary and secondary outcomes. So when you are going through how to do a hypothesis, what specific aims you're going to do, I pulled this directly off the NIH website. This is kind of their outlines, and usually people want to see at least 3 specific aims. So you can have a primary specific aim, which basically is a restatement of your hypothesis in a more aiming method. And I'm going to show you an example of this in one of my most recent projects. And then your secondary aims, you should always have a few of those. And these are looking at things that can be achieved as like clear endpoints and really understood. So I thought this was a really nice list put together that's in very layman terms that is super easy to understand and kind of what happens as you're thinking through this process. The NIH has a lot of very, very helpful things on their website when you're going through how to design this process. So you get your idea, you did your literature search, you formed your hypothesis, you formed your specific aims, and now you have to figure out how you're going to design this and actually do this. So any questions up to this point? See something in the chat. Oh, I can't open the chat. I don't know what the chat says. I'm sorry. We're going to have to look at this at the end. You guys can feel free to like talk during the middle of this. You can interrupt me at any
Dr.
point.
Tyson, the chat doesn't say anything.
Oh,
I got you.
Thank you. So the best way I think I can take you through an example of how to formulate thoughts is with one of the most recent studies I did. So this is our study here, talking about the purpose, the hypothesis, and those specific aims. So first off, you have to do your background search, and it has to be relevant. It has to be a novel idea. It has to change your field, right? So your idea's got to support something new. And usually when you're writing a grant and you're asking for funding, within the first couple of sentences that somebody picks up in this thing called a cover letter that you're going to send to this grant person saying your intentions to apply for this grant is blank. And you better hook, line, and sinker and catch them, just like when you're writing a personal statement for however many, God, Lord knows you've all written like a bazillion personal statements. And if you intend to do fellowship or further training, you're going to continue to write personal statements for the rest of your life. When you're attending, they turn into a cover letter, your goals of why you're applying for this job. So they do not end at the end of training. I hate to burst your bubble if you don't know that. But, just like you grab someone's attention in that first couple of sentences of your personal statement or people lose interest, the same thing's going to happen when you're presenting an idea that you need money for to do. So this is kind of some really important background information that I just condensed. So 1 in 10 babies are born premature each year, and they all lead to neurodevelopmental delays. Okay, well, that's pretty important. This is a common problem, and this is a big problem in society. So there's my hook, line, and sinker. So things that we know that decrease neuromotor developmental delays: skin to skin, breastfeeding. There's lots of therapies that have been studied: touch, massage, all sorts of physical and occupational therapy. But OMM with neurodevelopmental outcomes is not well studied. There is also something called this test of infant motor performance. This is a very well validated and reliable screening tool, and it is very specific and sensitive for predicting neuromotor developmental delays used in infants that are 34 weeks corrected gestational age all the way up until a few months of age post-term equivalent. All right. So I present all this information because the first thing I want people to know is this is a problem. It's a common problem. It's a big problem. We know that there are things to help it. We know the thing I'm interested in has not been well studied, so this is novel. And I have some kind of tool that I'm going to use in this study that is very, very reliable, sensitive, and specific for what I'm looking for an outcome for, okay? The purpose of this study. Now, I just told you background, but a purpose is very different, and it's still different than your hypothesis as well. So, pay attention to kind of, if you go back through these slides and you actually do design something like this, the steps that are taken here for how they're all worded just a tiny bit different, because as you're applying for grants, all these things are going to be asked of you to write. Like, what is your purpose? What is your hypothesis? What is your aims? So the purpose of our study is we ultimately seek to evaluate if osteopathic manipulative medicine improves neurodevelopmental outcomes for premature infants. As a first step, we are going to conduct a blinded, randomized control trial of preterm infants born less than 34 weeks and compare the risk of neuromotor developmental delays as measured by this TIMP, this test of infant motor performance, and infants who receive OMM compared to those who just receive standard of care. Now, I have just summarized the entire study in like a couple of sentences. And that's where taking this idea and all these thoughts you have to get down to this point, okay? So now I've written what I'm looking to do and what my steps are going to be taken in order to do that. My hypothesis is just a tad different, but it's a spinoff of what I just said. So this is your prediction, right? This is what you are writing. Like I said, just a few lines, as clear cut and less wordy as possible, that take a prediction about a specific population, and you want to know what that outcome is going to be. So here's my specific population, or my premature infants born less than 34 weeks, and I'm measuring something very specific. Okay, so high-risk preterm infants born less than 34 weeks of gestation who receive OMM compared to those who receive supportive standard care will have improved neurodevelopmental scores on this test of infant motor performance. So I'm predicting if we do OMM on these babies, they're going to have better neurodevelopmental scores, okay? The primary aim is literally just that, except now you are stating it as like an aim, a goal that you're doing. So this primary aim is to determine the difference in these TEMP scores in infants who get OMM and those who receive only standard of care. So let's go back a second. So the hypothesis is stating that prediction that I think these kids are going to have better scores, but your aim is simply stating, my aim is to look at these scores between this population. So that's your difference. But the primary aim always directly reflects what you were testing in your hypothesis. Your secondary aims are your bullet points. Let's say this study is all done and my TEMP scores are not changed at all, or they're worse in the OMM population. Well, so when you come up with secondary aims, these are things you're pretty dang sure you're going to see. And the reason they're not my primary aims is because these outcomes have already been proven to be associated with OMM in premature infants in Italy. There has been no major clinical trial on a large subset of neonates done in the United States yet to prove this. So when designing this, I could have said, you know what, I'm going to take another country's data and they show that these babies go home sooner. I'm going to do the same thing in the United States and see if it applies to our population. Could have started there. That's not the most novel thing. This kind of takes it one step further, and I'm almost certain, based on the bazillion pieces of Italian data out there, that if I do OMM on these babies, similar to a protocol that they did, that my baby's going to go home sooner. So that's why I threw that in there as a secondary aim, because even if my hypothesis is wrong, it doesn't mean that the babies who received OMM maybe don't have better neurodevelopmental outcomes. Maybe this test isn't the best test to reflect that, or maybe there's other factors that are coming into this. Maybe these babies need more or less OMM. There's a lot of confounding variables that you also have to think of when designing a study. It doesn't really mean that maybe your hypothesis is wrong as much as it is the way that it was designed and studied may not have reflected an accurate outcome of what you were hoping to predict. So secondary aims are there to help back that up, because your secondary aims, they may very well be relevant to what your outcome is. And they're helpful. However, when you were statistically, I'll go back to this in a minute. When you were statistically designing a study, you are going to do what's called a power calculation in a clinical trial. So a power calculation is done by a statistician, and it is looking at how many patients you would need to have to detect some kind of significant difference in your outcome population. So this is where I didn't know a whole lot about this until I got to fellowship here with people who just produce just bukus of data every single year. And you can design a study and say, I can recruit 20 kids, or I can recruit 50 adults, and I'm going to take 25 of them and do one thing and 25 of them and do another thing, and I'm going to look at the data. If you do that in a big grant funding cycle, you are immediately dismissed. And the reason for that is because you have no grounds for saying that if you recruit 50 patients, that you're going to come up with anything statistically significant. So you have to do it reverse. You have to say, I have an outcome data. I know that, so for me, I'm studying this test of informative performance. I know what difference I need to look at within a certain score parameter based on the publications of this test to say, hey, this is meaningful. This is statistically significant to say this kid is a moderate or a low or a high risk, as long as their scores are within 6.5 difference. Okay. So that's a standard deviation. A full standard deviation for my study would be 13 points difference, but 6.5 points is a half a standard deviation. So I'm even going more specific than a full standard deviation for what the score should be different in my kiddos. So when you're powering, you go through full power, 90% powered, 80% powered, 70, 60, 50, and the statistician gives you this big old breakdown of a percent of power prediction for how close you're going to get, how many babies you need to study, how many people you need to study, so to get some kind of statistical significance. So this is within like an 80% guarantee, and 80% powered to say we're 80% sure that if you recruit 126 kiddos into the study, that if your test is accurate like you think it is, and if you're making a difference here, we should see a statistical significance, 80% likely. Okay. A power less than 80% really starts getting iffy. That's when your data is meh. So 80 and above is an excellent powered study. I went with the lowest possible power I could to make a statistical significance because I was a fellow at the time. And let me tell you what, recruiting 126 babies over a 3-year process of fellowship is a hot mess, and it is a challenge. It is that is a large, this sample sizes like this are usually done over a period of several years, like a 4 to 5 year goal. So doing this in this timeline is rigorous. If I would have done 90% power, I needed like 160 kids. There's just no way. Okay. So some of this was feasibility of what I could do and the timeline that I had to produce this. All right. So that is your power calculation. So back to these primary and secondary aims here. Oh, I'm frozen. Sorry, guys. It'll catch up in a second. So with these primary and secondary aims, when you have the statistician go and say, I need to know how many kids I need to recruit in the study, they're going to do it off of your hypothesis and what your primary aim is. So looking at these secondary outcomes, let's say my primary aim at the end of the study is something that wasn't true, wasn't relevant. I didn't find a difference, but I found out that my length of stay is ridiculous. It is substantially different. When you publish data like that, people always raise an eyebrow because they know that my study is powered to predict this outcome. Whoa, sorry guys. Can you still see my PowerPoint okay?
Yes, we can still
Okay,
see
good.
it.
So they know that your study is powered to this outcome. They know your study is not powered to these outcomes. So the first red flag you're going to get when you publish articles about secondary outcomes, when your primary outcome is irrelevant and didn't have statistical significance, is, well, we don't really know how conclusions you can draw about this because your study wasn't powered for that. The opposite is true if your primary outcome is statistically significant. If it's a big deal and you were right, and it does prove that, then people follow suit. Then that means your secondary outcomes likely follow suit along with that. That's very challenging for me because that's an outcome. Should it really matter if your primary versus secondary is irrelevant or not? No, but I'm going to tell you that in journals, you're going to see people critique the snot out of that. So anytime you design a study, you have to have inclusion and exclusion criteria. So this is mine for this study, for example, and you state them very clearly. This was pulled out of thin air, and this is a situation where no study for neurodevelopmental outcome in the osteopathic population had ever been studied. So I'm one of those people who really did start from complete scratch. So not only do you have to come up with inclusion and exclusion criteria, but you also have to pull it from somewhere that makes sense. You can't just like guesstimate and make it up. So I went and looked in other therapy books, massage, PT, OT, and said, when is it safe and when is it not safe for those therapies? I went and I looked at the Italian data and said, what population did they include? What did they do? And I had to come up with some kind of thing to the best of my knowledge. For example, there's really no publication on alternative therapies for babies who have big old head bleeds. We know that the really big head bleed babies end up with the most severe outcomes, but we have no idea whether therapies are safe. So I was cautious and excluded those kiddos because the last thing I needed was to start a study halfway through. We're pulling some data collection and realizing that the babies who were treated all of a sudden had more head bleeds than the other. My study was going to be shut down immediately. Okay. Not that I think OMN would do that, but I have no grounds to say with any literature that it's safe. So until you have some kind of feasibility study and safety and efficacy study, you cannot say something is or is not safe. So I am working with a study design that I don't have much grounds to say that I have safety data to do any of this. So this took a while to come up with. And then I excluded kids who had surgery and major genetic and metabolic effects, neuromuscular diseases. We know those kids are going to have really severe delays. And when you can't move right, or you've got cerebral palsy that's going to develop in a few months, you're not going to be just like another kid who was premature when that person goes to do a test of infant motor performance. We know those kids are automatically going to score lower. So this is part of that sample selection design where you need as much of a like-minded population and very similar populations in your inclusion and your inclusion of subjects, because in both a treatment and control group, because if you have kids that you know are going to automatically have an outcome difference just based on other factors, then they should not be included in your population. So to go for OMM, you just have to fit the gestational age criteria that I'm studying. You have to be deemed stable by an attending. You have to have consent from a parent. And then when do you start OMM on a premature infant? There is zero data, none, to state when you start. But I'll tell you, looking at all the occupational and physical and massage therapy data, everybody starts around 28 weeks, corrected gestational age, and those babies do all right. So we were going to start at 28 weeks. The results of the study show that it may be quite beneficial to start it earlier, but you had to start somewhere. So I hope this, guys, gives you an idea of how to do that. And then, you know, I say 28 weeks, but the next question I got from the IRB was like, well, how do you know when to start? Gestational age is not reflective of every baby having the same neurological state. So what are you going to look at to know when to start? And what are you going to look at to know when to stop? So that's the next thing, is to come up with how you start the encounters to do osteopathic manipulation. So these are physical signs of autonomic stability that are used within other therapy worlds to say a baby is stable enough to have a massage, or a baby is stable enough to undergo physical therapy. It's in both of the data. Now, OMM on little neonates is much, much, much less direct and much less aggressive than either massage or therapy. So again, I think that, you know, these signs are very strict to include a baby for OMM, but you got to start somewhere with something that's published to have some kind of backing. So this was our criteria to know when to start an infant. So they had to be at least 28 weeks, and the nurse and I had to go through a checklist to make sure everything was true about this child before they could start the study. And then when to stop an encounter. So anything that lasts for greater than 15 seconds is considered a pretty significant event and signs of stressors in populations. And these are also stop criteria in massage and therapy worlds, when to discontinue a massage or discontinue things. So that's where I pulled this from. And then you have to say how you're going to draw your population. So a statistician helps you with this too. The best predictor of neuromotor delays out of anything else and all the things that affect neonates is gestational age. The next closest thing is birth size. So any neonatal literature you look at publishing on neuromotor stuff, it's either stratified by how small and how big they are. So there's some kind of weight cutoff in their inclusion criteria, or some kind of age cutoff. Because age was a little more predictive than weight, we decided to go with age. I could have gone more specific and done age and weight, but I would not have met my numbers of 126 patients if I did that. So I knew that I was limited in order to complete this study, that I had to do it this way. And that was going to give me not only the best data I had, but an actual outcome that I could produce. Things are always going to be able to be designed better than what you can physically do. And that is something that as you begin research, you really have to check yourself, knowing what you're actually capable of completing, because it's useless to the world if you can't even complete your study. So our statistician did something called a 1-to-1 randomization, meaning that she ran these cute little spreadsheets on a subject ID, 3-digit subject ID, patient number 301, for example. And I had all these numbers for all these babies based on their gestational age. And when it came time for the trial, and I decided that I was going to put a baby in a trial, I pulled a packet out and I pulled it from 1, 2, 3, or 4, stratum 1, 2, 3, and 4. And that just told me either they're included in the treatment group or they're included in a control group. And they were already predetermined and had a number, and that number was associated with a specific treatment, either in the control or in the treatment. And I had a packet for each gestational age. So doing it in this way is tricky because I may end up with a couple more babies overall who were in a treatment or a control group, because each one of these sectors have their own treatment and control group randomization. And then what did I actually do? So the treatment group of babies receives osteopathic exams and manipulation for a maximum of 15 to 20 minutes every 7 to 10 days. We are very blessed that this study was incredibly easy to be designed because we have a curtain that draws right around our isolates in our NICU. So it is just me behind the curtain with the baby. The parents do not know, the nurses do not know, nobody knows except me, whether I am doing OMM on these babies or whether I'm just standing there staring at these babies, okay? So it is excellent for blinding because of the way our unit is designed. If we did not have this kind of setup, designing a blinded study like this would have been a lot more challenging. So know your environments, know what you can and can't do. The reason I said 15 to 20 minutes is because that's what all the Italian data says. They publish stuff about 15 or 20 minutes long. And the first place I presented this research was at the AAO convocation. And I got up there and people said, well, how do you really think a 28-week infant's going to tolerate OMM for 15 minutes? And I said, I have no idea. So when we did this, I gave a time limit versus a time goal. So I cut the babies off at 15 to 20 minutes, but I will document how long they tolerate it for. And how long they tolerate it for is when they start reaching those stop criteria, the apnea, the bradycardia, the hiccups, the arching, all of that for greater than 15 seconds. The second a baby starts doing that, I write it down. And I know it. This one tolerated it for 5 minutes. This one tolerated it for 7 minutes. And collecting data like this through this study starts giving a foundation of how long a baby can tolerate OMN at a specific gestational age. The treatments they get, I was very fortunate that there's something called the NEO model produced by Italy, and it is a very clear-cut, excellent pathway for how you should screen and evaluate and perform OMM on a neonate and an isolate and a NICU. And they did this on 100 babies and showed no adverse events. So this is where I was blessed that I was not starting from scratch, because I had a model with a very specific protocol that showed to be safe. And that's all I needed. So I follow the same kind of techniques and the same methodology of screening that they do. I do whatever I think the baby needs on whatever area the baby needs. I just evaluate the baby the same way that this model did. So same thing when we're going through, I have no idea what strain patterns that I'm going to find in a normal baby at a certain gestational age. There's no data on that. So every single baby has an OMM sheet, and every single baby gets documented just absolutely tooth and nail for what was done and what was found and what the outcomes were at the end of the treatment. And then the control group, they're cute. They just get stared at. So I stand behind that curtain, same timeline, same frequency. And then they just get standard of care. I don't touch the babies unless they have an event. So that's how this is done. Once they get this every 7 to 10 days, starting around 28 weeks gestation, they get this all the way up until they turn 36 weeks corrected gestational age. So their last treatment possible date comes at 35 and 6 weeks corrected gestational age. And then all of my stuff completely stops. I'm done. They get no more treatment or not treatment for the rest of their stay in the NICU. And then in comes an occupational therapist who has gone through very rigorous training to know how to adequately perform this test of infant motor performance on infants. Somewhere between 36 to 37 weeks corrected gestational age. She comes in, she does this sheet, she does the scoring for neuromuscular testing, and she has no idea whether they were in the treatment or the control group. She can ask the parents what they think about things because it doesn't matter. The parents don't know whether they're in the treatment or control group, and neither do the nurses. So at that point, I am then blinded from what the outcomes are on the test of informative performance. And she keeps all these little sheets in a locked secure data box and in a separate file. And I have all the treatment and control group knowledge. So I have not seen a single TIMP score. The study is just now completed until every single patient is discharged from the NICU. Once the study is completely closed, enrollment is done, and the study is shut down, then I can see the TIMP scores. Because if I saw anything along the way, it could create a bias of how I thought people were doing and stuff along the way. So that's how we've kept this blinded. And then it's always nice when you write grants to have kind of a overview of what your goal is, what you're doing, because words can be confusing and words are a lot for someone who reads grant after grant after grant or article for submission after article. And they're like, all right, what are you trying to say here? So pictorial representations are always a win. I have never seen anybody get an NIH award without doing something like this. So, this is just an overall picture of what I'm doing. So they have to be born at least 23 weeks. They can't be born earlier than that. We now do babies earlier than that. We did not when I started this study. And somewhere between 23 and 28 weeks, they get enrolled into the study. They can't have any of the exclusion criteria. And depending on the stability of the baby, I approach families somewhere where I think it's good and they're stable enough that I think they're going to be able to enroll. And I just enroll them and I don't do anything else. Once they hit 28 weeks, then I start talking to the nurses and make sure that they meet my START protocol, make sure that they meet all those ability to have good observation of their environment and that they can move around and that they're good from that standpoint. And then I'm doing grand rounds, you can come in, but and then once we do that, they get either treatment or non-treatment weekly per se until they hit 36 weeks. And then I stop and then boom, the TIMP is done. And then they're discharged. So that is an overall representation of their course for the study. So how to receive funding. You have to have a biosketch. This is different than a CV. There are templates for biosketches on the NIH. If any of you would like to see a biosketch, I'm happy to send you mine, about 500 other examples. They are a very short and succinct CV per se that is very related only to research and what you've done, what current research, what publications you've contributed. No one cares about a CV or a resume in grant world. They only care about a biosketch. So you should have one of those. You should have a very solid, innovative, feasible plan that's going to have a great impact or nobody's going to get attention. And then you need to be asking money from sources who actually care about what you're doing, whose missions are in alignment with what you are studying. You should definitely take a grant writing course. I've now taken 3. There's nowhere through medical school that they teach you how to be a writer, how to write grants, how to understand the statistical jargon. To actually get a large NIH award, something called a K1 or an RO1 that you'll hear about, you don't only have to do all this stuff and fellowship and residency, but you got to go through and get some kind of advanced certificate in clinical research or an advanced statistic certificate, leaning towards like a master's program, because the NIH won't even consider big time awards until they know you've taken courses to actually understand what you're asking other people to give you statistical outcomes on and how they're producing these powers and what that actually means for your study. Because if you don't understand why they're doing certain things, you can't really write a conclusion about it and have an idea what you're talking about. You have to know your budget. When you ask for money, it has to be down to the dime of what you were asking for, why you were asking for it, who's also already received money. There's something called seed money or starter money. If you have that, that's gold, because when people see part of your study has already been funded, they are much more likely to give you the other half of the money. And then get involved in the organizations that you want your money from. So I started as a fellow for OMM on the Louisa Burns Osteopathic Research Committee, just to have some clue of how grant funding worked in this committee. Before you know it, I went from a learner to a grant reviewer, and now like I know what gets passed, what doesn't, why it's failing, why certain people get funding and what they don't. And I know that submission process and that grant process back and forward. If you can get involved in a process that you may later be applying for, that's absolutely golden. That's probably the best way for you to understand how to ask for money from a source that you understand when they give the money. Okay. So obviously, when I apply for grants for organizations that I'm part of, I have to recluse myself from that process for that cycle. I completely step back and I have no idea what's being applied for against me at that timeline, or that would be a bias. So that's possible to do. So get involved. And then major funding sources. You know, doing osteopathic research is something that the world needs. It's what's going to keep our field sustainable. I'm sure you all have experienced situations when you've been on a rotation and you potentially are with an allopathic person and they say, well, I don't know about all that stuff. There's not a lot of good data for that. And you're like, yeah, I know, but clinically we see it improve stuff. Yeah, that's not going to fly long term and ever make a really significant impact in like the world of medicine unless we can prove at the same rigor and level of investigation that everything else is done within the allopathic world. That's when you start getting attention and respect for what's being done, is when you can talk their talk, walk their walk, and speak what they're speaking at the level that they can speak it. So all of these ridiculous years of training that I've done and fellowships and bazillion certifications has been to get me at that level of understanding at the level that they think. And I've been very blessed and fortunate to be at a really strong fellowship where there are a lot of funds and grants and big time grant writers to understand how to do this. But they are pulling from a pocket of money that is very used and is very limited and is highly held tight from the NIH or other sources such as that. Gerber Foundation is another big one for babies. We have total separate funding that we can dip into for the exact same kind of level of research. And there's all sorts of money just laying out there, ready for your ideas to go to work. The American Osteopathic Academy, the AOA, has like literally $100,000 grants, $50,000 grants. I mean, I've like been a part of medical students who have received these $50,000 and $100,000 grants. So you can absolutely do it as a trainee. You may not need that much money as a trainee, but I've definitely seen it done. Then there's the LBORC, this Louisa Burns Osteopathic Research Committee through the American Academy of Osteopathy. Every cycle they give 10 grand out max. So this is a great starter grant to grab, especially for a trainee with a attending that does OMM or can help lead that. That's just a small pocket of money to start a really good pilot study or beginning things. And then there's the Osteopathic Heritage Foundation. These people are endowed with osteopathic funds and osteopathic money. And we are talking like millions of dollars in osteopathic funding. These are the big guns. Once you start producing really big clinical trials and you make your way up to that level, that's when you have the attention of the Heritage Foundation. So don't think that you've got to go for the same grant process as everybody else just because that's what everybody else does. I think doing osteopathic research is actually so much better to actually do because we have ridiculous amounts of funding sources that other people do not have access to when they come up with their ideas. So plenty of money out there. Okay, any questions? I'm all done. No.
Thank you, Angela. That was wonderful.
You're welcome. All right. If any of you have more questions or you think of a research project, don't hesitate to email me. I'm happy to talk with any of you about how to get started with stuff like this. I hope you all have a great day, okay?
Thank
Thank you,
you.
Angela.
You're welcome.